right, good evening, everyone. Can you all hear me okay?
Yes.
All right, I'm so honored to be here with all of you tonight. I want to begin by introducing a couple honored guests with us. Manager Shannon Jones, thanks for being with us tonight. Manager Cynthia Valdez, thank you for being with us tonight. And a particular thank you to our community care colleagues, Joyce Sloan, Tara Trower. We're honored that you've been meeting with us as well. Thanks to all of you for taking time to be here. It's an exciting feeling to be here at the start of our second budget season, really beginning by listening to all of you. And that is such an important part of our process. Some of the key things that we did last year actually emerged from some of these conversations, including a focus on food insecurity. One key thing that comes to mind has actually become a central focus of all work that we've done. So these conversations really do matter. I've worked through a couple slides here. So this is me. I want to begin by actually reaching back to a time in our city when it wasn't assured that we would save our springs and that we would have the beautiful city we have today. And I recall learning from Commissioner Shea the role that she played in seeing that vision, standing firm for that vision, and sometimes taking some inbound fire because not everybody wanted that vision the way that you did, Bridget. But I wanted to acknowledge that it is on the shoulders of leaders like Commissioner Shea, who did the right thing for the right reasons, even though it was hard, that we have the city we have today. So thank you. Appreciate that. And I want to connect that to what we're doing today here. So we believe, as I think many of you do, that our world-class city deserves a world-class health system for everybody. Not two standards of care, but one amazing standard of care that everybody has access to, so that we can directly attack the life expectancy difference east and west of I-35. 10 years, if you go to the city's website, or 20, 25 years, if you look at the areas that are most affected. How do we take care of that together? How do we envision closing that gap together like we did when we formed the city that we have today that we love? Together with that, our mission at Central Health, which I also just been so proud to represent, is that by caring for those who need us most, we improve the health of our community. So we're going to talk about that work and caring for those who need us most. And I'm at the privilege of kicking us off here. All right. I always love to lead with this slide, whether it's with this community conversation or in our new employee orientation or in a number of other venues, because nothing is more important to the work that we do than our people, the people who do that work. We have, in the current state, a feeling of family, a feeling of mission, a feeling that we know why we're here, and it's not a job to any of us. I get to welcome every single new team member at Central Health, and not a single person who joins our organization is doing this only for the paycheck. This means something to us. We have a reason to be here, and when we look left or right, we are willing to support each other because this is something that matters to us. I'm not just going to clock out and leave you in the lurch, because that means probably somebody else is going to be left in the lurch. We're here as a team, and as we grow and everything that comes in the future and the years to come, my commitment is that we're going to do everything we can to maintain that culture. If we stay together, there's a sense of mission and purpose and family, then I think we will be successful. This slide is probably too small for you to read, but I believe in front of you have a handout that is something that we shared last week at a CEO roundtable. Some of you were there, for example, Reyes and Pedro, thank you for being there, and there may be others who were there as well. I saw Seth Dockery here. So I'm going to touch on a couple points there, not all of them, but you have this in front of you. When we get to the Q&A, please feel free to jump in. So this last year, the first bullet point up there is around the expansion of specialty care. This was the first year that we actually enacted the Central Health Strategic Plan. Let me take us back for a moment. How did we get there? So for a number of years, we heard, this is prior to my time here, but as I studied our history, we listened, and then we measured, and we confirmed that in specialty access across the board, from dental care to cardiology care, from kidney care to foot care. There were either moderate or severe gaps in access across the board for our patients. And so the community made very clear it's not enough for y'all to plan and pay for that care. We need you to go out and build and close those gaps. And so for a number of years prior to my joining, our team responsibly planned and saved to be able to create a 7-year runway. To imagine you're flying a plane from coast to coast. We fueled enough fuel in the tank to be able to fly this plane for 7 years. Over more than $700 million of allocated projects to directly close measured gaps in care in direct response to the voice of our community saying, planning and paying for is not enough. You have to go and build it and deliver it. So this was year 1. We stood up 16 specialty care and diagnostic service lines. I came from Brooklyn and prior to that Boston, where I was the chief of medicine at 2 different CTNet health systems. If we stood up 1 new specialty service line in the year, we thought we were doing a good job. 16 was something I'd never heard of. Now these specialty service lines are all young. They're all not even teenagers, right? I'm looking at our CMO, Alan Shalsha. We have a lot of work to do to deepen and stabilize and optimize and connect, but there is now access. In some cases, wait times, let's say for a colonoscopy to screen and diagnose your colon cancer, drop from over 12 months to a matter of weeks. There are some specialties like cardiology, where if you need to be seen, you could be seen today or tomorrow, I believe. And that was not the case before. It's a little known fact that there's a new-fangled way of doing an imaging study of the heart, an echocardiogram. We have the most advanced echocardiography machine in the area, in our clinic, in Rosa Zaragoza, so you can actually watch in 3D that heart beating and see where the problem is and see it as a patient. So the access that we have now today is not perfect, but it is very different than it was just a year ago. We heard you. Get started. We're going to go deeper. We're going to go broader. But this is a very important year. That's why that's the first line up there. The second line up there is around opening the Rosa Zaragoza Health Center. For those of you who haven't seen it, it's open to you. Please come take a look. I wasn't there at the launch of it or prior to the build of it, but those who were told me 2 words. They said Freddy Krueger. I wasn't there for it, but it gave me a picture in my mind. It does not look like that today. So I encourage you to take a look if you haven't seen it. It's amazingly light and dignity and welcome. And I think it really speaks to people as a place that is safe, a place that is kind. And on the wall of that health center, you will see a mural of our One Trunk Many Branches, which you could drive by as you drive by. It always lifts my heart when I see it. And as I believe I see Stephanie McDonald in the room, we're going to get our certificate of occupancy March 10th.
Well, now we're first patient.
First patient March 10th, at long last, at Del Valle. So thank you to everybody who got that over the line. I'm just going to pause and give a round of applause. And I believe it will be another beautiful, dignified space that reflects world-class health system for everybody. No second level of care, but a first level of care that we can be proud to come to with our families. There's a couple of things on here that we're going to touch on in depth, so I'll skip them for now, the Bridge program and the Medical Rescue program. On the addiction medicine side, amongst many other things we did, we expanded medication-assisted therapy services, I believe at the Capitol Plaza site, in partnership with our community care colleagues. And we've got amazing leadership in addiction medicine at community care. I believe, to be honest, we've graduated our 4th cohort of medical assistants in partnership with the Austin Community College. Why is that so special? On the one hand, medical assistants are so important to the care, to the teamwork, and they're in high demand. And so the fact that we are actually training and reviewing and hiring on our own is wonderful. We have 17 new hires from that cohort, I believe, from those 4 cohorts. But the other reason that matters is the Austin Community College serves our community. Their typical student is a single mother of color with, I believe, 1.3 children. Of course, you can't point to this is an average, right? 1 to 2 children, working 2 to 3 part-time jobs while she is trying to go to school and get her degree. And so if we empower that person, that woman, with this kind of a job and bring her in, this is going to impact her kids, her family, our community. That ripple is going to extend out in a powerful way. So we're particularly proud of working with the ACC to create these opportunities, and there's more coming behind it. We're going to talk about community health worker training. That was a key item that came up at our roundtable last week. So really appreciate the ACC. There have been a number of ways this year that we have partnered with our Black leaders in our community. Black Men's Health Clinic, the African American Youth Harvest Foundation, and within that, the Trauma Recovery Program, which is a national best practice model, help you heal after trauma, perhaps lay down your arms and find the healing you need as an alternative to where you feel you've been. The Hungry Hill Foundation, aligning housing, job training, and healthcare all together. We are honored to partner with these individuals and these teams. And part of the reason that's so important is because we know that health begins with trust. If we trust the care that we're getting, we're going to talk about whole person care more broadly, everything we need to thrive, and we're going to be able to customize that care to what people need. But trust is a big hurdle to clear. If the person I'm talking to grew up with me, our people know each other, maybe we worship in the same church, that is a much easier distance to cover. If there's lived experience of incarceration, lived experience of homelessness, we are talking at a level that immediately allows us to get to trust. And if that individual then has the health system behind them on tap, right? They can pull in the health resources. That's the kind of partnership that we want to be able to develop here, and we're honored to have taken some additional steps this year with those partners. Moving on the list, at the request of our Travis County Commissioners, and with the close work and partnership of the sheriff and her health team, we've begun to work with the jail health team to provide access to these specialty care services in our setting. The very first person we saw in foot care actually was about to lose their foot. They were about to get that foot amputated, and the same day we saw them, the very first patient, we got them into the right care setting, revascularized that foot, saved that person's foot. Since then, we've developed infectious disease services, cardiology services, and we're broadening out to provide access to our full range of specialty care for folks who really need it. So really proud of that work. Working closely with Integral Care and our Austin Police Department, leadership of our county, to think about jail diversion. If you need mental health care, we should get you mental health care rather than incarcerate you. How do we do that safely, efficiently? Continue to work with HAM, and continue to deepen our ties with ECHO. This is a year where we've really built common cause with ECHO in the full range of housing services across our community. We've visited Denver to learn together. We've come back and process these learnings together. We're working side by side. We show up with healthcare services. Our housing partners meet in the middle with housing resources so that we can put that together around the individuals who need that care. That's going to be the subject of a lot of work to come, so I won't steal that thunder, but just a shout out to ECHO and leadership there. And then a very important last bullet here that I know is a point that's been important to Commissioner Shea, to many of us, is Sendero Health Plans. This is part of our system. In 2022 or 23, we had 6,000 members enrolled in that plan. It was quite small and underwent a leadership change. Last year, I believe we were around 13,000, and this year we're at 29,000 people enrolled in that plan. Far more than we expected. You know, it's a good problem to have. There was a period of time where the wait time on the calls was very long because all of a sudden we were more than twice as big as we were just previously. But to the credit of that team, we stabilized, worked down those queues, and we're excited to see where that goes. And despite that growth, the total administrative cost actually went down by 8%. So I'll just leave that as sort of a kind of a wow. I'm really impressed with Sendero leadership and excited to see what comes beyond that. All right, a little bit of touch about the numbers. This is actually from the 2023 annual report. We have more information coming out shortly in the 2024 report, but we served about 1 in 9 Travis County's residents, 155,000 people, with over $150 million eventually invested from your tax dollars toward this care. There were 52,000 uninsured Travis County residents below the poverty limit who received care through the MAP program, another 76,000 up to 200% entitlement through the MAP basic program, and in total over 600,000 primary care visits facilitated through our network of primary care partners, principally Community Care, but also Peoples, Lone Star, so working with all of our key health center partners. And then we are here in Precinct 2, as you all know, and one of the things that we do as we produce these demographic reports every 2 years is try to drill down and ask, well, where are our patients and where are the needs? And so these are two of the focus areas that are really jumping out to us. And as a preview, we're about to release the next iteration of the demographic report, I believe in the next week or two, so please stay tuned for that. But the north central Runberg area has the highest concentration of families in poverty of any of our focus areas in the county, more heavily Latino and Spanish speaking. The North Travis County is also a very heavy area for us, a little less of the absolute count of families in poverty compared to Runberg, a little more folks who prefer English as their first language. In both areas, cardiovascular disease, diabetes, hypertension, key issues, so a common need there. And a relatively high proportion of our enrollees in map-based in these areas actually use services, a lot of them in the North Central Health Center, but with a spread across different areas around the county. So this is just a snapshot to share that we try to understand who are the people we're serving, where are they, what do they need, what are the transportation needs, the access needs, and so on, and that informs our planning here. And I think my final slide is this one. This is just a tee up for things to come. We built this slide about 11 months ago. At that time, it was a design slide. We were calling out the fact that if you are unhoused and you have been to the hospital at a major surgery, you need chemotherapy, you need IV antibiotics for 6 or 8 weeks, that's just not going to work if we discharge you to the street. And that, unfortunately, was the usual case. And so the first thing we did was stand up respite services, a place to heal for that 6 to 8 week period after that acute event. But we asked the question, if we then discharge you to the street after that, have we really solved the underlying problem? It was a clear, resounding no. What's going to happen there is you may have healed your wound, but you are still without the services you need, without the housing you need. You are likely going to end up back, picked up for misdemeanor in the carceral system or back in the emergency department. So we designed this slide to say, well, what if we don't let you go, at least for that first year? Once we embrace you, we don't let you go. And we try to ensure that you have the best practice standard of care, which is housing that's right for you and care that you need without any breaks in between. And we knew that to do that, we'd have to get around the table with folks who do nutrition, transportation, housing, coverage support, and other things like education, faith-based services, creative, pets, whatever it is that you need for you to thrive, so that you can get the housing you need, the care that you need, and so you were able to navigate beyond. And we know this journey extends beyond a year, but we said at least a year. Let's go at least a year. And this was just a design slide last year, and I'm delighted to report that parts of this slide are no longer hypothetical, and you're going to hear about some of this from our team. And so with that, it's been truly an honor. Thanks for your patience with my comments, and I'll hand over to my colleague, Dr. Alan Schulster, our Chief Medical Officer, and I'll be here to join in the Q&A and to follow. Alan.
Actually, we're going to, borrow your mic?
Yes, absolutely.
We're going to do a mic switch, because that gives me a chance to ask anyone with a question. We are going to have Q&A in a little while, but as we do this mic change, anybody have an issue that they would like to address that? You have to raise your hand. Okay, we're going to keep rolling. You ready?
I'm ready. Everybody hear me okay? All right. Good evening, and thank you for having us. This is an exciting opportunity really to share information about the work that our teams have done and the ongoing work that needs to be done. I'm going to briefly introduce some of my colleagues, and then we're going to kind of ping pong back and forth and kind of share this presentation. I'd first like to introduce Dr. Phoeba Thomas, just kind of wave. Phoeba is a clinician She's a subject matter expert as far as our Bridge outreach team. She's also an electronic health record expert and is really leading the build within our infrastructure. And most importantly, she's an amazing patient advocate. Monique. So Monique has been with our system for 11 years. She has served both within community care and within Central Health. If you think about mobile, street, any outreach that may be designed in an atypical way to meet the patient where they are, chances are it was designed by Monique. So if you talk about a patient champion, she is exactly that. And then Stephanie McDonald is our Vice President of Enterprise Alignment and Coordination. Where's Stephanie? Stephanie is right up here. And Stephanie is really going to lead you through some new builds and some developments as we progress. So Pat touched on the fact that prior to a couple years ago, individuals within our environment were discharged from hospital, from skilled nursing facilities, and other clinical environments, if they were unhoused, at times directly to the street. And the folks that we have the honor of caring for are complex. Anytime they're discharged to the street, there was about a 50% chance that they would bounce back to the healthcare environment that discharged them, right? You cannot get better if you, let's say you had an amputation, right? There are hospital criteria after which the hospital would discharge you. How can a new amputee actually improve his or her health care, right, and well-being if they discharge directly to the street? So one of the first things our teams did is really start contracting for respite. We contracted, I think now we have contracted close to about 30 beds. And we're going to talk about the reason that we need to build our own respite environment. Contracting for care is okay, and we really count on the folks that we have those contracted agreements with. The only thing is that when something changes within their environment and we lose beds, it's very hard to rapidly recover. The other thing is that about 50% of our patients who enter the respite environment either self-discharge or administratively discharge, which means the environment is not conducive to them actually improving their health and well-being, or they break rules, right? If we actually own and operate our own environment, we can create the rules. And we can actually lean into the patient care, wrap our arms around the patients, and really ensure that they thrive. This is Mr. Peavy. He was actually the very first patient that we saw within our respite environment, previously unhoused for over a decade. He had previous comorbidities, so illnesses before we were fortunate enough to meet him. He was hit by a car, multiple fractures, spent about 2 months in the hospital, spent about 2 months in the skilled nursing facility, and then spent about 2 months with us, right? He was able to get through his rehab, and because he spent that period of time with us, we were able to connect him to the social services that he needs. And when you think about respite, respite is an environment where people can heal physically, where they can heal mentally, and just as important, where we can connect them to the social services that they need. And Pat spoke to the fact that we have people in respite for 4 to 6 weeks. The data shows that if we are really going to succeed in this environment, we need people to sit in the respite environment for anywhere from 4 to 6 months, because that's how long it takes the system to really make all of these connections, to ensure that they travel that road to success and do end up getting housed, which means we need more respite beds, and we need more respite beds in an environment that we can do quality control and really cater to our patients. I think I've touched on most of this already, but patients get discharged from skilled nursing facilities, from the hospital, and we have amazing mobile EMS and other teams, and the teams now know our how to contact our respite folks, and can just pick up the phone and say, hey, we have a critical need now, can you all help? This really shows kind of the current number of beds, and we actually have another contracted partner that we can flex as need be. Many of you know the old Children's Hospital. So the education center that sits on the corner of 15th Street and I-35, that is a Central Health building. And that building, thanks to Stephanie and thanks to her team, is currently being redesigned so that before the end of this summer, we can actually house 40 to 50 patients, 40 to 50 respite individuals ourselves, right? And the way we have designed that is specific to ensuring that if they break a rule, we can step back and say, all right, is this a teaching opportunity? What do we need to do in order to adapt our system so that we facilitate the patient really succeeding? At the same time, in that environment within the CEC, there will be a clinic that can provide care to the patients, so they won't get care within their respite environment, or it becomes more like a skilled nursing facility, which this is not. But the clinic will be a short walk in the same building. We'll also have PM&R, which is kind of a physical medicine physician that will be starting with us this summer, PT, OT, speech, and other resources that patients can get. And not only the patients that sit within respite, but obviously all the patients who are in our charge will be able to receive that care. All right, I'm going to hand this off to my colleagues now, and I don't want to get Ted upset. Ted, what mic would you like them to use?
I am on my way.
All right.
Hi, everyone. We're so excited to tell you about the work that we've been doing with the Central Health Bridge program. We're not hearing.
Hello?
Yes.
Sorry about that. Hi, everyone. We're very excited to tell you about the work we've been doing with the Central Health Bridge program. As we know, when people struggle to access healthcare, it results in more ER visits, chronic conditions that get worse over time and cause end organ damage, and just delayed access to care that causes worsening conditions. So the Bridge program was a way to address this and increase access to healthcare. So I need to hold this mic very close to my face for y'all to hear me, huh? So at Bridge, we offer comprehensive healthcare, and what that means is not only do we address someone's medical needs and maybe refill their blood pressure medication or do their pap smear, or if they need a joint injection, do that, or refer them to specialty services. We also address non-medical drivers of health, like if someone has a transportation barrier, needs help getting an ID card or a coordinated assessment, connect them to our community partners and help just all the care the patient needs. And, so we provide care in two models. The first is our Bridge Clinic at Capitol Plaza. So this is our brick and mortar clinic. People come there and receive all the services that we offer. And we also have our Bridge Mobile Street outreach teams. And this is truly meeting the patient where they're at, whether that be with community partners or out on the street where patients are, especially those who are unable to access healthcare in the traditional model. Next slide. So initially, Bridge started as a way to serve respite patients and serve their medical needs and connect them back to healthcare in the system as a whole. And that was in June of 2024. By September, we had expanded our community partners and especially our partnership with EMS. And we became an approved site for EMS to divert 911 calls that were medically appropriate to our clinic. And these patients were often very disconnected from the system, not accessing care in traditional models and using the ER for all of their health care. And we're able to catch those patients and connect them to the system and really meet them where they are at. And this year, we have been really excited about our Bridge Mobile Street outreach and expanding those services. So we've conducted multiple outreach events with our community partners. I see our partners from Hungry Hill here today. Very nice to see you here. And then also provided some mobile street clinical services, and soon we will be expanding to 4 or 5 more mobile clinic sites. So we'd like to tell you a little bit about the impact that we've seen over the last year. I'm going to turn it over to Mo for this.
Hello, everyone. Y'all forgive me, I'm a little bit nervous. But as Dr. Thomas was saying, we started this program at the Bridge Clinic, well, respite. We started in, during January of 2024 to where we are now. We partnered with EMS and APD. We were able to get people into warming shelters. We were able to get people just somewhere where they can be safe, where they can be warm, and like Dr. Charles said, where they can actually recover from whatever illnesses or whatever it is that they have going on. Next slide, please. And Dr. Thomas is going to share this story about Mr. J.
Mr. J is just one of many patients that we've been able to help. And so he first came to the clinic through our partnership with C4, and he had struggled with severe asthma, had so many wounds on his legs, and he was staying outside downtown, and it had gotten so bad that he was unable to walk. And so at the first visit, we were able to clean his wounds. We were able to curbside a dermatologist to review the case and prescribe some medications and antibiotics. We were then able to see him again for a second visit where we were able to provide additional wound care and some lab testing. And by the third visit, we had been able to change his medication. And this is a picture of our nurse manager with Mr. J. And by that third visit, he was able to walk and doing much, much better. This is just one of many stories that we can tell. Even last week, we saw someone that we had seen at one of our outreach events at Hungry Hill, and he had been just staying on the street, didn't really know where to go, and struggling because he had been off of his mental health medications. He had had high blood pressure that was untreated, and so many things. And so we were able to see him at our Capitol Plaza location, get him back on his medication, connect him to therapy, connect him to a psychiatrist, and we're planning on seeing him back in a few weeks just to make sure that things are going well. And he has our direct line to call if anything comes up in the meantime. Next slide, please. These are a few pictures of our team.
I wanted to take a moment to brag on our team. We have the pleasure, this is our third week of going to the Integral Care Diversion Center. It's a 25-bed facility that provides an alternative for jail. Folks who are in a mental health crisis are able to receive care and support, get the meds that they need, and get connected to whatever services they are, because I'm sure a lot of you know, a lot of people are in jail who just really needed care. They needed medical care, so they're there unjustly, in my opinion. But this, going here, we were able to see a total of 8 patients. Of those 8 patients, 5 were new from ATC. They were all in-house. Of those 5, we were able to get people connected to mental health services as well, behavioral health. We were able to refill medications. We got, there's one woman who had a family history of breast cancer. She had over 40, had never had a mammogram. And we were able to get her connected with that as well. And as far as follow-up visits, we have patients that come to see us because they would prefer to come to see us if they have that option, because they know that they're going to get the love and the care and the support and be treated how they're supposed to be treated. As well as the van that was purchased by Central Health, this first van that was purchased by Central Health. And just for me personally, I want to take a moment to say, when I first started doing this, it was literally the faith of a mustard seed. To see where it is now is truly amazing and is beyond my wildest dreams. So I'm very proud of the work that I myself don't have lived experience, but I have lived experience adjacent. And so I know if people can get connected to the care that they deserve and that they're entitled to, they can absolutely make a turnaround. So, thank you.
I want to thank you, Mo, because we had the opportunity to visit the Therapeutic Diversion Center on Monday, and Mo, thank you and your team for opening the doors, not to me, but to the media. So we had the Austin American-Statesman reporter and photographer there, and it's the first time that I can remember where a situation where patients, clients, that were there were coming up asking to tell their story. We didn't have to ask anyone, would you mind, if we talked to at least 5 people walked up and said, I want to tell my story, and I want to thank the team, Mo and others, for the work they're doing. And to see you and the team in action is heartwarming and inspiring, and it's also, we're seeing life-changing results. So thank you so much for doing that.
All right, thank you. I'm going to touch on a few of the services at some of our clinics. Thank you all. Pat shared a little bit about medication-assisted therapy. Matt is a resource, Suboxone, for individuals who may have an addiction disorder. This is kind of a long-acting opioid and really allows them to stabilize and just live more full lives. Our system partner, Community Care, has moved into our Capitol Plaza clinic, and so some of the patients that Dr. Thomas and Mo just spoke about, the more resources we can bring in kind of a one-stop shop, the greater the chance for our folks that we serve to be successful. So you can see some of the other services that exist there, but that MAT clinic is, I think, the newest addition and really a high point and a critical need for our patients. The East Clinic, which is also a shared location with our community care system partners, was actually the first clinic that we got up and running. As many of you may know, build timelines are not always as predictable as we would like them to be, and so sometimes we have to think on our feet and look at opportunities. The one thing we would not slow down on is providing the access to the patients on the timeline that we promised that access. And so this was not the original plan. The original plan was to move our specialty patients directly into the Rosewood Zaragoza clinic, which ended up being our 3rd specialty clinic. We moved, I think, GI and Home into this clinic and podiatry. We then grew podiatry. The reason podiatry is really important is, 10 to 15% of the individuals that we serve are unhoused, right? And so tibial tuberosity, so from the knee and down, obviously, whether it's wound care or foot problems, a lot of our patients have a lot of those challenges. Many of the folks who we serve are physical laborers, and so they also have problems, and then people just have foot and ankle problems. And so it was critically important to get this service line up and running. What we also did here is diagnostics. Again, the more of a one-stop shop that we can provide, the greater the chance for the folks that we serve to succeed. So, weight-bearing x-ray, which is kind of a unique x-ray and one that's hard to find in the city, as goofy as that sounds, and can really differentiate some of the diagnoses for the folks that we serve. Then you see the ABI and the TDI, and this really looks at blood flow and what the tissue health is. And so these are services that we can actually conduct, within our clinic. About I think 10,000, 12,000 individuals within the system have a diagnosis of diabetes, and as that disease process progresses, so the vessels are at risk, and so the more we can really, not only do treatment, but look at some of the diagnostic resources, to better tailor that treatment, the better our patients are. This is Rosewood Zaragoza. So it was supposed to be our first clinic, it was our 3rd clinic. We filled up the other 2 with specialties. And so you can see some of the specialties that exist here. Pat spoke of cardiology. We have Dr. Harrison is our first cardiologist, 2nd cardiologist comes on this summer. He was the chief fellow within the UT Ascension system and chose to join us. And is really building up that program. We actually have an advanced practice provider as well, so cardiologist coming on this summer will be the 3rd cardiology provider in that space, and we can provide pretty advanced treatment. We're also looking now at some of the nuclear diagnostic opportunities that we have. for our patients, again, so they don't have to go anywhere else. I did want to point to palliative care. I think when we hear palliative care, one of two things happens. We either don't know what that is, or we affiliate palliative care with end-of-life care, right? What palliative care really is a group of individuals who can wrap the care around patients who have either complex medical or social needs. And so if we think about our patients, there are very few that either don't have advanced social needs or don't have advanced medical needs, and many of them have both together. So what we can do is we can consult our palliative care team, and we can then increase the opportunity for individuals to thrive while they still have these diagnoses that may or may not be terminal, right? And so it really improves quality of life, and those are frequent touch points, and it may be that it's our palliative care physician, our palliative care advanced practice provider, pharmacist, dietitian, case manager, social worker, but there's a team that really wraps the care of those patients. Okay.
Helen, will you explain what medical optimization is?
I would love to. When Ted asks if he can ask you questions, it's a maybe, maybe not. That one I can answer. So medical optimization, many of our patients need some kind of surgery, need some kind of diagnostic procedure that may be somewhat invasive, but their blood pressure is out of control, their diabetes is not managed, and that puts the patient at risk if they undergo that procedure. And so what we're able to do is to get the patient into care with a pharmacist, physician, nurse, and if it's calling the patient on a daily basis, if it's ensuring that they have access to their meds, right? A lot of times it's not that the patient wouldn't take the med, they have no way of getting there, or they don't understand the instructions. And so medical optimization is, again, making sure that people have the opportunity to succeed in their care. And with that, I'm going to hand it over to Stephanie.
Thank you. I have the privilege of being a constituent of Precinct 2, and so thank you, Commissioner Shea, for your public service. One of the reasons I'm really proud to live in Travis County is because everyone here, I believe, the majority of us at least, really believe in the ideas of health equity, right, Dion? We believe. We believe that wherever we live within the county, our fellow community members should have the same access, and that everyone should be empowered to live their healthiest life. And so from a community listening session several years ago, Rick, Manager Jones, we know and learned that our fellow community members in Eastern Travis County, specifically the Hornsby Bend community, the Del Valley area, and Colony Park, did not have the same access. They did not have the same transportation options to get to care. And so we, with our colleagues at Community Care, made a commitment to build 3 new health and wellness centers. The first one in Hornsby Bend opened last year, and I'm really delighted to know that there is a full-time provider. We started this year strong, and I'm really excited about getting to serve that community with both healthcare access as well as community resources. It also has one of the best playgrounds in the county. Thank you, Manager Alvarez. And now the second one, this is so exciting. It's going to see its first patient on Monday. And so the Del Valley Health and Wellness Center, which is 18,000 square feet, it is a comprehensive primary care medical home with dental services for both adults and pediatric patients. It will have primary care as well as the first drive-through pharmacy in our system. And we're really excited about getting to serve that growing area of the community that does not have access to pharmacy services, and then also being able to be very customer and patient-centered and delivering that care and service. We have the third site in Colony Park in design development right now. We are working with the City of Austin and their master development plans to get the infrastructure, the road in place. And we are wrapping up some of that design development work, and we should be able to make that very public to our board very soon, as well as to the larger community. And it's exciting. That was actually maybe the largest of our 3 health and wellness centers, and we're really excited about a commercial kitchen in that space and comprehensive both adult dental and primary care services, also a very robust community program, community resources there. And then I'm going to try to advance this. Oops, wrong way. So more to come in the Del Valle Health and Wellness Center, a very large community gathering and the grand opening event later on this year. And many of you, how many of you remember going to the Sears store at Hancock Center? I'm dating and aging most of us here, but you remember, I remember my now husband, I bought him a Craftsman tool chest and loaded it in the back of my Acura Integra, so the hatchback came real handy. Well, that site, if you haven't been by lately, is under construction, and we kind of took it back to its original columns, took all the walls down, all of that kind of really aged 1990s stucco, and I'm excited about getting underway for the first time where we are going to offer primary and specialty care services under the same roof. Full comprehensive pharmacy, lab services, and we are hoping to make this a place that can be a one-stop shop, imaging and diagnostic imaging there. And I think, just so you know, we were getting impacted. There's a little bit of a infrastructure project going on downtown Austin through on Interstate 35. I know Jim Walker's here really following some of this. It is impacting 2 of our clinical locations, including the convenient care, the kind of walk-in clinic that community care operates in the parking lot here. So we are having to rehouse those services, and the other clinic that's really, really important to not just Travis County, but to an 8-county region is the David Powell Clinic that serves those in our community with HIV and AIDS, and will be rehomed here at the Hancock Center. And then it'll also serve as the kind of leadership nerve center for the Central Health System. So that will include the executive teams of Community Care, Sendero, and Central Health. In the future, it is where these meetings can happen in the future. We will have our public auditorium in the lower level for our board meetings, as well as these kind of community events. And so we're really excited about that, hopefully getting in before the steamrollers take down the clinics. So the clinic level is really the priority, with hopefully being in that space in April of 2026 for this, some of those clinical services. We are really thinking thoughtfully about how we are laying out this this building, but how we kind of integrate our services and how we really think about the patient experience and making sure that we're being very patient-centered. I think one of the ways that we are doing that is through the help of this next person and a process called integrated facility design. And as we really talk about the Cameron Center and kind of comprehensive services for those experiencing homelessness in our community, we really hope to lean in into the lean methodology and integrated facility design as we try to build out these care continuums. And with that, I'm going to hand it over.
Can I stand behind the podium? Is that okay?
I think it's okay.
Yeah, thank you.
I'm not in charge of that.
Good evening, everybody. My name is Tim Heikkinen, and my role at Central closer. Either that or okay. So my role at Central Health is to help the organization navigate major change, and one of the focus areas of change is how we transform.
A little louder, please. Hold the mic next to your mouth. We can't hear you.
Okay, sorry.
There we go.
Better? Yeah, so one focus area is how we design and develop and improve our processes for better access and health outcomes. And we're looking for guidance from a very unlikely source, which is Toyota. And you probably ask them, what does making cars have to do with healthcare? So let's watch a brief video. And this video is called The Toyota Effect, and at Harbor UCLA Medical Center. Can we please play the video? so we can get technology to work.
There we go.
My name is Lizeth Urias, and I've been a diabetic for 15 years, from the age of about 17. I wasn't able to afford medication, so I stopped using it for about 5 years. My eyesight was blurry and I see flashing lights throughout the edges. I did not know that diabetes would cause this type of damage to my eye. It would be nice to be able to see my family, my surroundings, especially my nieces and nephews.
Sorry about that.
See flashing lights throughout the edges. I did not know that diabetes would cause this type of damage to my eye. It would be nice to be able to see my family, my surroundings, especially my nieces and nephews. I'm sorry. I lose my energy a lot. Focusing through one eye, it drains me. So I feel like I'm not there for them as much. It's hard on me. I try to be the stronger one.
Lizeth is a great example of our patient population. She's young and she didn't have access to care. We are a county-owned facility and our mission is to serve the underserved. She came in with diabetes that was out of control, high blood pressure. In addition, she was bleeding into her eye.
We had a surgical wait list that was hundreds of patients long, and to not be able to intervene in a timely fashion was really, really difficult to deal with. Lizeth, patients like Lizeth would have to wait for months for surgery, and in the process were going blind.
Toyota was contacted by the Harvard UCLA Medical Center, and when I heard that many patients were going blind waiting to get service, I actually couldn't believe it. How can that happen in the United States?
People ask all the time, what on earth do making cars have to do with hospitals and healthcare? Hospitals and health systems are looking to the Toyota production system to improve, and we reached out to them. We really didn't know what was wrong. Sometimes when you work in chaos, you don't know how to get out of it. So what Toyota did for us is they helped us learn to see our own environment. And so we did observations. We stood at the clinic and watched the process flow.
We just had a table with all the charts lined up, one big mountain full of papers. Doctors were frustrated, nurses were frustrated. So with the color-coded system, now we know red is laser. Bam, here's your patient. It's so much easier for everyone.
Physicians were spending more time in the hallway than they were in the clinic. And the reason why is that they didn't have the supplies they needed close by. Now that sounds like a very simple solution, and it turned out to be. We asked them, what do you need at the clinic side?
Part of Toyota's message is that this is our hospital. They're not going to be here to tell us how to do things. They're going to come here and teach us how we can identify ways to make ourselves better.
It's changing our culture. It's transforming us as an organization. We're not the same organization we were a year ago. We're taking some of the lessons that we learned from the eye clinic and are spreading the change throughout the hospital.
Can open both eyes from the back? Great. You did really, really well. Over the past 2 years, we've taken a surgical backlog that was hundreds of patients long, and we've eliminated it. It's 5 o'clock, and all the patients have been seen?
This is the best project I have ever had. At work, we only do work. Here, we actually help people.
I never would have thought that implementing the Toyota production system would help save lives or keep people from going blind, but it has.
Can you make out how many fingers I'm holding up?
It looks like one,
Very good. And
two,
very good. Can you see the screen?
looks like an F.
Very good. She was blind, at least in her left eye, she was blind. And what the surgery means is that she's going to have good vision for the remainder of her life, and she has many, many years ahead of her.
Being able to see my family. I think that's the most important thing for me.
There we go. Okay. So, we're going to do the same at Central Health. So we're going to implement the Toyota production system. We're not going to call it that. We're going to call it lean. So we're going to try and become leaner for better access, to reduce delays, and for better health outcomes. So I'm going to tell a short story. So Maria, she's one of our patients. She's 45 years old. And one day, she felt the lump, and she gets worried. She calls the call center and requests an appointment. The first available is 2 weeks out. She gets anxious. She goes on the internet and Googles her symptoms. It starts to affect her work.
Can we hear you a little louder, please?
Starts to affect.
That's all I just speak right into it. Yep.
It starts to affect her work, and she's 2 weeks later. She goes and sees the doctor, and she's told to get a mammogram. She calls the call center, books an appointment, has to wait for 2 weeks. Gets the mammogram, is told to wait for 2 weeks for her results. Gets the results, is told to get an ultrasound. Books an ultrasound, waits 2 weeks, and continues her journey until she sees her specialist. The entire timeline from start to finish took about 3 months, and the service she received from the providers was only 2 hours. So that's a process that does not flow. It's plagued with delays. Imagine if Maria had access to a system like this. She calls the call center and is told to go to, tells her symptoms, and is told to go to the breast clinic that we have set up at Central Health in one of our new facilities. She sees a mid-level provider who does her physical exam, is told to walk over to the mammogram room, she waits 10 minutes, gets her mammogram, waits for the results for 10 minutes, is told to get an ultrasound, walks over to the ultrasound room, gets the results, gets her biopsy, sees the specialist. So in 3 hours, she goes through that process. She has a plan in hand, and her wait time was only an hour. Imagine a system that wasn't fragmented, a care delivery system at Central Health that wasn't siloed, where you didn't have to wait for months to get your care. Instead, we had an integrated system, end-to-end, from primary care all the way to post-acute care, where you didn't have to wait. It was easy to navigate. It will be coordinated, and that would make the care the health outcomes better for the residents in Travis County. Thank you.
Now we'd like to invite you to ask questions. All of our speakers will be available. We'll be playing the Pass the Mic game. So we'll take some questions as a group. Then we are going to break out and allow you time to speak one-on-one to our Board of Managers that are in attendance, Manager Valadez, Manager Jones, Chair Kitchen. But before we break out, maybe as a group we could share questions or feedback from anybody in the room. We'll bring a mic to you. And if you don't mind, just state your name before you speak and speak into the microphone. Anybody have any questions or feedback or comments? This is not a shy group, I know that for sure. Dion. Anybody? Thoughts, comments on anything that you heard? I'm going to come back. Go ahead. Okay.
Hola, buenas tardes. Voy a hacer mi pregunta en español, en Spanish. Gracias.
Good afternoon. I'm going to, good afternoon everybody. I'm going to make my question. I'm going to present my question in Spanish.
Antes que nada, muchas gracias por la invitación a esta reunión. Me siento muy contenta por haber estado enterada de todo lo que han informado.
Thank you very much for this invitation to be present here. I am very, very happy to be able to access all of this very important information that you have given us.
Perdón, no me presenté, mi nombre es Selene Domínguez.
Oh, I'm sorry. My name is Selena Domínguez.
Selene Domínguez.
Selene Domínguez.
Ajá, y vengo en representación de la organización Camina ATX.
And I came representing the organization Camina ATX.
Es una organización comunitaria sin fines de lucro, pro inmigrante, pro comunidad.
This is a community organization, non-profit organization that provides pro immigration and pro community.
Tengo una pregunta acerca de en este ambiente sociopolítico que estamos viviendo actualmente, ¿de qué manera hay una estrategia o algún plan que se tenga para apoyar a aquellas familias de inmigrantes trabajadoras, familias trabajadoras de inmigrantes indocumentados, que puedan, qué estrategia aplicarían o si hay una estrategia para ellos?
My question is, given this moment that we are living, this socio-political moment that we are living right now, my question is if there is a strategy in Central Health that is working towards the undocumented immigration persons or families, if you are really thinking of doing something about that, given this moment, right?
Sí, y por último, entendemos, yo creo que muchas personas entendemos la comunidad inmigrante indocumentada que ha decidido valientemente quedarse para resistir por la razón que sea. Creo que están conscientes de que el servicio médico tiene un costo, pero también entendamos que no son personas simplemente por no tener un estatus legal adecuado, deciden vivir aquí y son parte de toda lo que es la comunidad trabajadora, ¿no? Que construyen este país también.
And we as members of this community, many of them undocumented people or families or persons, we understand that access to health care is costly, is expensive. But we also, I have to say, that many of these members of this community are very valiantly or bravely deciding to stay here despite all the risks that they are coming under. And to me it's important to emphasize that they are not only, they can be undocumented, but they are also very important members of the community. And so that's the context of my question.
Sí, entonces, si existiera un plan donde incluso la comunidad inmigrante indocumentada considerara hacer un pago, si es que se va a poder tener acceso a los servicios médicos, pues que se hiciera un pago considerado en el entendido que ya hay leyes como la GA46, que está de alguna manera intimidando o atemorizando a la gente para ir a buscar un recurso o un servicio médico, ¿no? Lo que queremos evitar es también es contribuir a enfermedades o a pandemias o a una dispersión de enfermedades que por no tener acceso al servicio médico, ¿no? Gracias.
So, and the last part of the question is that we wonder if there is a possibility for these members of this community to contribute financially with part of the cost of having medical access. If there is a way or ways to make payment plans or some sort of that type of contribution to their health or access to that health. And that's a very delicate situation or question, because many of members of this family, of these groups, are very afraid, given that they are learning that going to get access to this, going to request medical access is a very tricky situation, right? Where they can be detained and being sent to jail or deported. And so I want to ask these questions because I think it's very important for members of this community to, they want to do also their part to contribute to minimize the risk of pandemics and things like that, right? So thank you.
Thank you.
Gracias por su pregunta, por su trabajo y su advocacia en la comunidad. Voy a responder en inglés. There's no doubt that this is a difficult time. There's a great deal of uncertainty. There's a great deal of instability. There's a great deal of knowing that we cannot stay still, but we must also be wise in how we respond to the moment. So I want to first acknowledge that we are in difficult times. The second thing I want to say is that our mission remains what it has always been, to care for those who need us most, and in so doing, improve the health of our community. We are here. We are staying here. Our doors remain open. And we are here to care for our community in collaboration with our partners, especially with our partners in community care. We are keeping our ears to the ground and listening to the national conversations at the federal, state, local level, understanding, what can we do? What are others doing? What should we do that will make a material difference for our patients? And there are three things that I want to share, and then I want to actually open up and potentially offer an opportunity for my colleagues at Community Care to add to this. But number one, our patients deserve to know their rights. We have that information available on our website. I've seen a couple versions of cards that different community members have, and we can make more available so that it's easy for our community to access and understand what are everyone's rights. And thank you for advocating yourself. I know in the work that you do, that's very important for our community to know. Number two, we want to make sure that our team members understand how to respond and what the process is should somebody come to one of our facilities. And we have a standard operating procedure that we have developed together with our community care colleagues. We have the same procedure. We believe consistency and responding as one can help create more trust. And so we're doing this in close communication. Our processes, our messaging, and our training for all of our team members to know what to do. And essentially, it is to treat whoever's coming in with respect, ensure identification, what they're there for, and then go ahead and escalate up the chain to the local supervisor and on up to our legal counsel and ultimately to myself so that we can appropriately respond to those requests in an orderly fashion. so that our team members feel safe. The third thing I'll say, and we talked about this a little earlier before the session, Selena, is that fear itself is one of the most damaging things here. There's actions and there's the fear itself, where we stop accessing the care that we know we need. We defer the care that would prevent the problem. We miss the opportunity to fix the eye problem before blindness ensues, or to catch the cancer before it metastasizes. And so we need to find ways to listen to that fear, to provide knowledge that we are here, we remain here, our mission remains the same, our doors are open, and ensure that we can still provide access to essential life-saving care. And I see my colleague Tara Trower, who is the Chief Strategy Officer, and also leads communications for Community Care. I want to provide an opportunity for Tara to also respond. Thank you, Tara.
Thank you so much, Pat. So yes, we are all listening and watching very closely. There's a lot sort of in the mix right now, both at the federal and state levels. Community care, one of the great things about being a public center and a federally qualified health center, which is a mouthful, but there are 1,300 of us across the nation, is the ability to share. Is the ability to share best practices, that we are not making this up just within our own microcosm that is Travis County, that we have others who are going through the same things, sharing them on a call once a week with the national group as well as the state group, as we both listen, try to anticipate and problem solve. And we are committed to provide all the care that we are legally able to provide. And currently at an FQHC, we cannot turn anyone away, regardless of their ability to pay. And so that is our commitment to you, it's our commitment to Travis County, it's part of the wonderful partnership that we have with Central Health. And we will keep listening and trying to figure out a way to do the thing that we know is right, which is provide healthcare access to those who need it most.
I'll just add that gracias por estar aquí. We're also, in addition to what Pat said and Tara, we are monitoring, and it's very important to collaborate with our community partners, such as yourself, to understand the fears and connect with the communities to share the message. And you know, we would love the opportunity to connect with you to better understand where we can make some connections. And so I just want to underscore the importance of also collaborations with community, because this is an area where it's very challenging, and it's going to take more than one or a few organizations. It's really going to take all of us to come together to help our community.
This is Carla Cavazos, our Chief Governance Affairs Officer and Deputy Administrator of Central Health, and a key voice in our community. Thank you, Carla.
Great question. Thank you for the comments and for sharing objective information that may be of help. Eligibility for those folks who don't have MAP, who potentially need to sign up for MAP, they can do the majority, if not all of that, remotely. So we understand that there is fear sometimes coming into the environment, but that can be done remotely. There are many care environments that can also be provided remotely. And so again, for folks who are fearful, which is very valid, emotion in this current environment, but please reach out and ask us, and we can share with you, which of those environments, we're going to try to meet the need. And I'm looking at, Community Care's Chief Financial Officer and Pat, and that finances should never be a consideration for people to access healthcare. At the beginning of COVID, fear or finances. At the beginning of COVID, people were having heart attacks at home and not going into the EDs. Let's not do that again. So if people need help, please reach out to us, come see us, or see us remotely, and let us be of help.
Okay, I'll just add one more thing. My name is Ivan Davila. I'm VP Marketing Communications at Central Health. Having gone through the pandemic with this team and having been part of this team for the last several years, I can tell you they're so committed to the mission and to the work that we do. And we're in this together. The very first sense that I got after we were hearing so many of the things that were happening was in a room with our leadership, and the sense that I got was we're still here to do our mission and we're in this together. Manager Valdez here present advocated and championed for us to put together a family support conference addressing and ensuring that we are including many communities, but specifically focusing on the Latino community, ensuring that we were speaking to them in their language. And so she asked me to talk about this, and so that's why I'm here doing this. And so it's coming up in September, and regardless of what happens, we're closely monitoring the situation. We're going to be working on any sort of mitigation strategies to ensure that people feel safe. If we need to take that event online to ensure that people feel safe but still tune in, we will do that. But it's happening in September, and we will be sharing more information with everybody as we know more. Thank you.
Thank you. Thank you, Yvonne. We're going to take a couple more questions, and then we are going to break down in smaller groups. I see Manager Jones' hand up. But if you have any questions or comments, please let us know. We'll bring a microphone to you, and then we will split up and do some small group conversations.
Okay, thanks very much. I don't have a question, just a brief comment. The Central Health Board of Managers is committed to taking care of its citizens. I'm so very proud to see our commissioner here. Because I want you to hear from us board members that we're committed to that. What's happening at the national level and at the state level will ultimately impact what happens here at the local level. And so we're going to have to step up to try to address that. We're going to need citizens and others to motivate and to organize to make sure that resources at the local level are available to address what the federal and state may not. So I just want to give you a heads up. The battle is a strong battle. We can win, but we all need to be in there together. And I want you to know that your board of managers are committed to making sure that we do whatever we can with the support of the county commissioners to ensure that that gets done. Thank you.
Any other? Commissioner Shea?
I have a comment and a question as well. We've been briefed a lot by Central Health, but I learned an enormous amount from this presentation, and it's incredibly inspiring the progress that you've made on helping take people who end up in our jails. And we know that is the worst place for people who have health care or mental health issues. The jails are not equipped to take care of people in those situations, but they're discharged from the hospital, they don't have homes, and they need help, and they're ending up in our jails, literally. So we've been in the process of moving from an incarceration model to a diversion model, and Central Health and Community Care and Integral Care are key partners on this journey. So I'm really impressed with the progress that you're making on these respite facilities and the care that's available to people. And I'm interested to know how you're paying for it, because that's where we've been struggling. We know when we divert people from our jails, we've got to provide medical and mental health care for them, and we don't have the resources to do it at the county level. So we've reached out to Central Health, Integral Care, Community Care. So I'd love to hear if you're able to speak a little bit to how you're able to pay for those services. But congratulations, really fabulous work in that arena.
And P.S., the Travis County Commissioners approved our tax rate and budget, so that question's not surprising. Thank you, Commissioner Shea.
Thank you, Mr. Shea. And yes, I mean, one key point is through your leadership and advocacy at the court level. But drilling down from that level, as we discussed during the last budget cycle, we significantly expanded our funding support for integral care. I think the current level folks correct me if I'm wrong, but I think it's around 26 million a year. Is that about accurate?
I'm looking at Nikki and Kim, does that sound right to you?
Vicki, am I in the right ballpark? Yeah.
That's the budget.
And so that's a significant increase year over year, and that's composed of multiple parts. In addition to the funding support, we are integrating our work within OCare. We spend a lot of time, team member to team member. We visit each other's spaces. We're in the diversion steering committee meetings with yourself and Judge Brown and others, Commissioner Howard and others, so that we're integrating that care. We're working with our jail health colleagues to provide ongoing specialty care to try to connect the care out of that environment to ensure that addictions care, for example, continues uninterrupted, primary care gets picked up. Our community care colleagues are critical to that. So we're doing all that work. I will also take a step back and say that at some level, whether we go upstream and provide care for our neighbors, or we wait for folks to end up in the hospitals and in the jails, the taxpayers bear that cost one way or another. And if we wait, they actually bear a much heavier cost, some of which includes people getting so sick that they can't work or that they die ahead of their time. And we actually have data around this. So for those who are interested in this topic, there is a report recently produced by the Episcopal Health Foundation, the St. David's Foundation, that I'd invite you to read. It's called The Economic Impact of Health Disparities in Texas. It goes county by county through the entire state of Texas, and it asks, if we missed the opportunity to care for you because of health disparities, we didn't prevent the blindness, we didn't catch the cancer when it was curable, we didn't prevent the need for dialysis, what is the excess medical cost of that? Right, that's bucket one. Number two, what do we lose in economic productivity because you weren't able to work anymore? And number three, if you died early, there is a way that health economists translate that into economic value. We would all agree that life matters. And actually, health economists give us a range for how much each year of life matters. And the low end of that range is $50,000 per year. So if someone dies 10 years too early, as we know from our ECHO recent mortality report around the burden and the impact of chronic unsheltered homelessness, you died 10 years earlier in that condition. The moment we get you safely housed, your life expectancy goes up by 10 years. You could translate that into about $500,000 of economic impact, as well as moral impact, but just on an economic basis. So does anyone hazard a guess, in Travis County alone, what is the economic impact every year of health disparities? I get a brave individual to guess who doesn't know the answer from a report. So if there's ringers out there, please don't answer. $1.1 million. Billion. Well, okay, that's exactly right. But I think you may know the answer now, $1.1 billion every year in Travis County alone. And that is an underestimate because it's not just the individual, it's the family, it's the community, right? It's more than that. Now, I asked a rhetorical question. If we had to pass a bill every year to pay $1 billion so that people, mostly of color, east of I-35, could die 10 to 20 years earlier on the streets and in our jails, would we ever pass that bill in Travis County? We've never passed that bill. But that is the problem that we're trying to solve. And so while we are increasing our expenditures, Commissioner Shea, to make sure that folks can safely heal after hospitalization, and that we accompany them without ever letting them go until they get safely into housing, and we divert from jail services and provide mental health care, and we provide transitions out of the jail services. All that is a resource expense, but I believe it will reduce the economic impact of health disparities. What we get for what we spend when we think about this at a broader level, where it all connects to taxpayers, I think it's actually a good investment. And we may end up with a slightly higher percentage on your property tax bill for the hospital district, but the benefits that we will see in economic vitality, in healthy years of life, and avoidable hospitalization and complicated care that can be prevented, I think will more than justify that cost, and that's how we're thinking about our deep connection and responsibility, demonstrate the value of our community support, which we do the grant for. Chair Kitchen.
Yeah, I just wanted to add back to your question, Commissioner Shea, about how we pay for this. A critical component is the housing, because and it's one of the things that's been missing forever, you know, in terms of respite care and also diversion. If you don't have a housing connection, people end up back in the system. And so what that means is we collaborate. Part of the way we pay for this is we collaborate with the county. I mean, the county put a huge amount of dollars into permanent supportive housing. Yes, 110 million. City put 100 million or so or more into housing also. So we don't pay for this all by ourselves, and we don't get it done all by ourselves. We have to collaborate, particularly on the housing aspect of it. So we appreciate that opportunity, and I just wanted to add that. And, yes.
We have 2 more questions, and then we are going to do a breakout session with you as well. So another familiar face.
Thank you, Ted, and elected officials, friends. Thank you for being present. Also, thank you for the opportunity to engage great information. I've had the privilege of serving along with these fine folks, and I've continued that activity as a fully insured patient within the community care system. So, one question and one observation. I wrote notes to see what my memory is like. Regarding respite care, I noticed in the slide presentation, it reflected 10 females, 10 males, yada yada, through 2023. And then an increase in respite care encounters 2024-25. However, how are you managing the children? That statistic is missing. Very important. And then I'll waive the comment because we're late.
Thank you. I'm gonna do what I do best and bring a mic to the expert.
Thank you for the question. Great question. And this is one that I'm not going to knock out of the park because we still have work to do. So I think about 80% of the unhoused individuals within our environment are male. About 20%, 20 to 25% are female, and a very small percentage also have kids. So we are trying to affect the greatest number of people that we can, and as we build out this environment, it's very difficult to build out an environment that is appropriate for kids, for men, and for women. And so the greatest need is for males who are unhoused. The second greatest need is for females who are unhoused. And so phase 1 is really building out kind of the male respite beds. At the same time, the very first clinical outreach of our bridge team was to the 8th Street shelter. Because if we can't build respite, how do we at least provide services for folks where they may be housed in a respite environment that is more conducive to them? So there are some resources for families, and we're hoping that as we build, there's another initiative that we didn't share. We purchased 3 buildings off of Cameron Road. And what we're hoping is that the build out that we do within the CEC serves as a learning opportunity for us, and that Cameron Road, that entire campus, right? We build out either for respite, for addiction disorder, for clinical care, or for wrap services that those folks need. And so it may be in that environment, but we still have lots to do.
Just one follow-up. That means that families will not have access. Families with children will not have access.
They will have access to health care, but based on the limited access that we have opportunity to build, it'll first be for unhoused men, unhoused women, and yeah.
We're going to take one more question, and then we're going to break up into smaller groups.
Okay,
Hi, can you hear me? I'm Sonny Burns, and I'm just going to comment quickly. We're talking a lot about diversion and housing, and we also had another report. The state auditor looked at the competency restoration wait list. So people in jail waiting to go to a mental health facility for competency restoration, which, by the way, is a huge waste of time and money. You want to do community reintegration, it's bullshit. So, what was interesting, and in this space we need to be talking about it, is that 676 people in a 5-year look back cycled multiple times. Here in Travis County, we were second only to Dallas with new charges, which means we need a higher level of care, and we keep talking about permanent supportive housing, rapid rehousing, and it is not working for many of our individuals. I also want to bring attention to youth, but in specific, intellectual and developmental disabilities, and these conversations have to stop if we are not talking about that group. Because I'm going to tell you that mental health facilities have exclusionary criteria for persons with IDD, autism, and or nonverbal. Even Dell Children's has this. So where are you supposed to go in crisis when you have IDD? And the DOJ had to come into Texas and do a report on the Texas Juvenile Justice Department. And the majority of people had IDD or autism, qualified for a very high special level of special ed services. And they did not know. They investigated Texas for over 3 years, you all, and nobody told them that the mental health facilities have exclusionary criteria for IDD, nonverbal, autistic. That's insanity. So we think that the state is doing something for these individuals. They are filling up our jails. The Texas Commission on Jail Standards has created an IDD advisory committee because so many people with intellectual and developmental disabilities are in our jails. We do not have appropriate housing, we don't have appropriate care, and that really needs to be a focus. Because I've literally seen near my house over here 2 people with Down syndrome living in the park. That's insanity. So I just wanted to make sure that we know that, and I know that we have a steering committee, Commissioner Shea and Kitchen. I've asked to be on it because I see who's on it, and y'all don't know the right questions to ask, and I just spent my whole day at the Capitol trying to educate people because HHSC is leaving this to the jails. They don't care. They're not talking about the most acute people. Doesn't matter what you do, they will be stuck in the streets because we don't have an appropriate residential model. You can do your health care all day long, you're going to still throw them to the streets and the jails.
Thank you, Sonia. Thank you for your advocacy and always speaking truth to power and ensuring that we don't lose sight of those who are vulnerable in these settings. And while this is not a direct and complete answer to your question, I do want to share to you and to everyone in the room that part of what we're doing is making sure that we are closely aligning our understanding of the problem and our ideal vision for the future with those key stakeholders who together with us are charged with this public health system. So working closely with Integral Care and the county, with the mayor and others to envision what was always intended in the different parts of this mental health system. You think about a physical health system. If we put up an intensive care unit with no hospital and no skilled nursing facilities and no rehab facilities, nowhere for you to go after you were in the ICU, that wouldn't make any sense, right? But that's actually what we've largely done in the mental health care system. We have the Austin State Hospital, which is like an intensive care unit for brain health, and we haven't yet realized the original vision of that ASH campus, which included all these other components, the analogy to what we have on the physical health side. But the good news is that we are on the same page around that. And I should include our colleagues at the UT Bell Medical School, Dr. Carol Alter, and the Dean of the Medical School there, that we are coming together as a health community to say this is what we need to take care of people and be able to move people from an intensive care unit to the next side of care. There are about 85 people who are currently living at the Austin State Hospital between 1 and 11 years after they've no longer needed to be at the Austin State Hospital. So if we
There's nothing for them, and I'm just going to say this, I'm sorry, Dr. Lee, but I have to say this. The people you just mentioned are not the people you need to talk to. That is why we have a new state hospital that when you ask the employees who work there, and my brother has been a resident for 16 years, nobody wanted that hospital. I have never seen a workforce so depressed to move into a shiny new building, and they were not part of the conversation. It happened up here with Kirk Watson and Dell Medical, but I can look in this room and see people who are working with people and they are not at the table, and that is why we will continue to build buildings and not invest in people, and everything will continue to worsen as we see it happening at this very moment. It's the wrong people. Those stakeholders are not the stakeholders you need to bring into the conversation.
Thank you.
Well, that's why we are here, listening to our community, and I appreciate your advocacy. And you're not wrong, Sonia. I hear you loud and clear. I read your messages as they come over, and we are doing our best to align and focus on the problem and the solutions. We have a flow problem. It may not be the only problem we have, but we need to build the components for a rational flow of patients to the right side of care. And that's not something we've done completely yet. I believe there is alignment that is needed, and we hope to be able to move those solutions forward. So thank you for your advocacy, Sonia, and the door is always open. Listen, thank you.
Thank you, Pat. Thank you, everybody, for being here. We are going to give you the opportunity, if you would like, to meet one-on-one with our Board of Managers. You've seen them here tonight, Manager Valadez, on the back corner, Chair Kitchen, Manager Jones. This will be an informal conversation. You're free to mingle with anyone in the room, of course, but if you have a specific question or comment you'd like for one of our Board of Managers, we invite you to join now. On behalf of the amazing folks, my bosses throughout the room, we really appreciate you being here. We welcome your feedback. You'll be getting a survey from us, so if there's something that we can do better next time, and there will be 4 more next times, we would like to hear from you. So thank you so much for being here.